So it's a great pleasure now to announce JoAnn Lindenfeld, Challenges and Unmet Needs in Guideline-Directed Medical Therapies for Heart Failure with Reduced Ejection Fraction.
Thank you very much. Well, that was a terrific introduction, and it's a pleasure to be here. My job today is to talk about unmet needs in heart failure, which I know you've heard some at this meeting, and then talk about the preliminary data we have that led to the approval of Baroreflex Activation Therapy. And I'll go through these pretty quickly, but these are the things I'd like to tell you about the unmet needs. That heart failure morbidity and mortality remain high, despite guideline-directed medical therapy, or GDMT. Exercise capacity remains poor, despite maximally tolerated GDMT, and it doesn't change much with guideline-directed medical therapy. Quality of life is also poor and doesn't change much with GDMT. And patient tolerance and compliance with GDMT is poor. But in heart failure with reduced EF, or HFrEF, we have made remarkable gains. So here I've just summarized to you the percent reduction in mortality with various therapies, starting with ACE, ARBs, sacubitril, valsartan, beta blockers, MRA. I'm just reading across hydralazine, isodil, SGLT2 inhibitors. And those are remarkable reductions in mortality, about a 75% reduction. But there are some things, even though all this medical therapy improves in heart failure, that it can't do or do completely. And those things are replaced by devices, and devices that we now already use on a routine basis. The use of devices in heart failure is not strange to us. For example, we've been using defibrillators and cardiac resynchronization therapy for a number of years, and now MitraClip, or transcatheter edge-to-edge repair for moderately severe secondary mitral regurgitation, is standard. So device therapy is not a surprise to us. And I think we now need to think of heart failure as, especially heart failure with reduced EF, as this intersection between medical therapy and devices, and expand that algorithm. But despite all of these medical and device therapies, and when we say GDMT, for example, when we said optimally titrated GDMT in the COAP trial, we meant guideline-directed medical and indicated device therapy, so it's both. But despite all of those applied appropriately, the residual morbidity and mortality remains high. This is from the latest SGLT2 trial in reduced EF, and you see that in the empagliflozin arm, there was still about a 25% reduction over 3 years, a 25% incidence of heart failure hospitalizations and mortality. So there is a lot yet to address in heart failure with reduced ejection fraction. And just to briefly summarize, this is a complex slide which Greg Lewis summarized, but what you see here are medications in green, a various number of inotropes in yellow, and then CRT in the blue. And you see that with the exception of CRT, this is the percentage increase in exercise capacity, however it was measured, that changes to the exercise capacity with medications are not that great. MRAs being the most, which is a little bit, I think, surprising to many of us. Yes, there is an increase in exercise capacity with inotropes, but probably at the expense of mortality. And then CRT, certainly more than with medications. And with medications, quality of life doesn't change much. So here I've summarized for you in green the intervention group, the medical group, SGLT2, control in yellow, and the difference in blue. And you can see these are KCCQ points, and they're very small. There was less reduction on the far right there with the sacubitril valsartan, but still the changes in quality of life, the mean KCCQ score is small. So we don't have nearly the improvement we would like to see in these patients who remain with a poor quality of life. And in addition, the long-term tolerance, up-titration, and discontinuation of guideline-directed medical therapy is high. This just recently, a very nice published study, showed you in dark green the full dose of a medication, and that's pretty easy with dapagliflozin because there's one dose really. But what you see in red, let's look at sacubitril valsartan next, right up here, and you see in red the discontinued treatment. In the light tan color, you see low dose, it stays at low dose. In the light green, you see that it stays at an intermediate dose, and only in the dark green is the maximally tolerated dose, the maximum dose of what we expect. So you can see that with sacubitril valsartan, ACE inhibitors, ARBs, beta blockers, MRAs, very few are on the maximally tolerated dose, and many have the drugs discontinued over the course of time for a number of reasons. So there are opportunities here. Morbidity and mortality remains high despite guideline-directed medical and device therapy. Exercise capacity remains poor and doesn't change much with medical therapy. Quality of life is poor and doesn't change much. And patient tolerance and compliance with GDMT is poor. So could devices help address some of these? There are a lot of things, as I've said, that medications can't do or do completely. Treat ventricular fibrillation, resynchronize the heart. Medications can improve dyssynchrony, but not completely. And then, of course, transcatheter edge-to-edge repair. Mitral regurgitation we know can improve enormously in heart failure with reduced EF, but not completely, and there's still a large number of patients for whom edge-to-edge repair is valuable. So here's just where we are. In the dark blue here, I've shown you for patients with a narrow QRS and a wide QRS. For a wide QRS, we have CRT in about 15%, maybe as many as 30, but probably more like 15% of patients. And ICD and CRT you'll see over there in the wide QRS. And then we have two devices to date, Baroreflex Activation Therapy, BAT, or cardiac contractility modulation that improves symptoms. And they both have 6-month randomized trial, and I will show you that for BAT today. And then, of course, we have MitraClip for secondary severe MR with an EF of 20 to 50%. So in there, for symptomatic improvement, are BAT and CCM, and I'll go on and talk to you about Baroreflex Activation Therapy for just a minute. So Dr. Foudim has already very well gone over the mechanism here. We know that in heart failure, both heart failure with preserved and reduced EF, that there's autonomic dysfunction, there's a decrease in parasympathetic activity and an increase in sympathetic activity, and those things can affect heart rate and remodeling and diuresis and vasodilation and the blood pressure. So we would like to optimize all of those things. And medical therapy can do that a bit as the heart remodels and improves, but not completely. I would also point out to you that this activation therapy does have one distinct advantage, and that is it's entirely extravascular. This right now is a very simple procedure done by the vascular surgeons. They say that surgery itself takes about 10 minutes to place the device over the carotid sinus, but it is extravascular. So, Baroreflex Activation Therapy was the first therapy both designed under the FDA breakthrough policy and approved under that policy. CCM was approved under that policy but not designed. And the idea of the breakthrough devices policy by the FDA was to get drugs to market on less than morbidity and mortality, to get some use and get them out there faster, and then go on and do morbidity and mortality. So that's exactly how the study was designed. And it was a 6-month study that randomized patients with HFrEF and New York Heart Association Class 3 heart failure in 1-to-1 randomization to optimal medical management, including appropriate device management, but in patients who were not candidates for CRT. And then the Barostim plus the same medical management. And the endpoints for this were 3 intermediate endpoints: BNP, 6-minute hall walk, and quality of life as assessed by the KCCQ score. And I would point out to you that to be positive, this trial had to have statistical significance of all 3 of those endpoints. Not just one, but all 3. So let me show you the results. And these results are the basis for which the baroreceptor activation therapy or baroreflex activation therapy was approved by the FDA on these intermediate endpoints. Exercise capacity at 6 months improved 60 meters. You can see the difference in blue. So the BAT group went up, the control group went down slightly, as we often see in heart failure studies. 60-meter difference. Quality of life, a 14-point difference favoring baroreflex activation therapy. Now, this is the Minnesota Living with Heart Failure, not the KCCQ, so it's better as the number goes down. So minus 14 is the same as positive 14 in the KCCQ. So a highly statistically significant difference. New York Heart Association class also improved, 34% improvement, improved at least by 1 New York Heart Association class. And BNP, there was a 25% reduction in BNP. And we know that from Paradigm, for example, it's the sacubitril/valsartan heart failure with reduced EF study, that as little as a 10% change predicted a change in mortality. So these were pretty highly significant intermediate endpoints. the basis for which baroreflex activation therapy was approved. Now, that study goes on in the breakthrough design for morbidity and mortality. And let me just show you first, all of these endpoints were consistent across all subgroups. So whether you looked at atrial fibrillation, yes or no, this is the Minnesota Living with Heart Failure, so down is a benefit, and in blue is the difference in the control and treatment group. You see whether there was atrial fibrillation, whether the ejection fraction was 25 to 35 or less than 25%, and whether it was women or men. All of these groups had an improvement in Minnesota Living with Heart Failure. The same is true for 6-minute hall walk. Here we see again in blue the difference, and you could see that there's an improvement with or without atrial fib in the low ejection fraction range, which is the only less than 25% approved device in this ejection fraction range, other than CRT and ICD, and then also in women. And amazingly, the benefit here in women was really quite remarkable for quality of life and 6-minute hall walk. So in conclusion, despite contemporary GDMT and device therapy, there are significant needs that remain because exercise capacity and quality of life are poor, mortality and heart failure morbidity remain high, and patient tolerance of symptoms with GDMT is poor. Baroreflex activation therapy uniquely works to rebalance the sympathetic and parasympathetic branches of the autonomic nervous system. Baroreflex activation therapy was approved by the FDA in 2019 based on safety and strong and consistent improvements in BNP, New York Heart Association class, quality of life, and 6-minute hall walk, all of them. This was a novel design, the first breakthrough design. There are no randomized long-term data on symptomatic improvements from device therapy for patients with a narrow QRS until now, and you're going to hear about that next. Thank you very much.